Hello, my name is David Cooke. I'm in Michigan, United States. It's in the northern section near Lake Michigan, about 60 miles from Chicago. I'm excited today to go over a talk with you about astigmatism. First, let me show some disclosures. My simpler title is Planning and Fixing Toric IOLs. In our title, I'm sorry we listed that I will be discussing the latest technologies. I don't completely believe in the latest technologies, so I'm not going to discuss those, and it was maybe a little misleading. The ones I don't believe in so much are Aura, the aberrometers that on the table will tell you what the refraction is, and so you can fine tune it. And the American Academy of Ophthalmology has recently released a paper that says that they don't believe in it either too much. And then the other one would be the systems that allow you to perfectly place the implant according to how you have it intended. And my concern on those is the value, the price versus return for that. And so I'll start. This is about how to use and especially how to remove toric IOLs. The reason I want to show you how to remove it is I want to decrease your fear in using these things. You have to know that you have a good backup plan and you can deal with a problem, or you're probably not interested in starting with it. So my goal is to make you experts, and an expert is someone who knows how to get out of trouble once they get in. It's not someone who never gets into trouble. What's my target? It would be someone without a lot of experience with premium IOLs, someone who understands phacoemulsification, and probably some or many of you don't, but that's my target, is someone who does, but does not have access to femtosecond laser or excimer laser. And that's because I don't have access to it. So this actually is some high tech, and this is your smartphone. And the article listed down at the bottom was a review, and they reviewed a number of articles on 6 different toric applications. They felt that the best, according to the literature, the best toric, I'll call it a smartphone application, I guess. The best one was the one on the right there. At the time, it was only available on Android. It's now available on both because I downloaded it last night on my iPhone. And then the one on the left there is the one that Graham Barrett did, and that's called the Toricam. I know it's available on the iPhone. I'm not sure otherwise. And the way these work is you mark the eye horizontally, then you line up the marks, and this picture, take a picture with this, and it'll tell you what the axis is, and then you can put your marker down, and you'll know what axis you're starting at. And there it tells you where the number is that it chose. Toric IOLs, I'm a big believer in toric IOLs. There are 2 huge benefits over other premium IOLs. Typically, they're less expensive. And I believe the quality, the optical quality is beautiful in these lenses. So you can use it in a weird eye, even though it's a weird eye, because that lens does not have any additional optical compromises. A lens that is going to give you a bifocal or trifocal, it has a lot of stray lights coming in there, stray light waves. And so it compromises something to give you something. Toric lenses compromise nothing in my book. I think they're great, and they are reliably our happiest patients. I want to tell you about the way these are named and the way I plan to talk about these during this talk. I'm only discussing 4 toric platforms, the ones that are available here in the US. I don't know a lot about the others. So the names that I'm going to use for this talk are the generic names, T3, T4, and those will apply, like a T3 would apply to an Alcon 1.5 diopter. And I'm referring to the toric magnitude here on the implant, not the power in the glasses or the power at the cornea. So it would be a 1.5 diopter, and the Alcon would apply both to Acrosoft and Clarion platforms. I will treat those 2 platforms differently in this talk. The J&J has the same increments. A 1.5 is the same as a 1.5 on the Alcon. And the Bausch & Lomb, they're slightly different. They're all a quarter of a diopter less. but I'm going to treat them as if they're the same. A change in the toric power does not affect the spherical equivalent of the lens. So if the lens is called a 20 diopter lens and it has 1 diopter cylinder, the spherical equivalent is 20. That's not true with the Zeiss toric IOLs, maybe some other ones, but Zeiss is the only one I know. For Zeiss, they treat it like it's a manifest refraction, and the spherical equivalent changes with the cylindrical magnitude. So a spherical equivalent of 20 diopters in the IOL with 1 diopter cylinder, actually that spherical equivalent is not 20 as is marked on the lens, but rather it's 20.5. I found a very nice table that you might want to look at. I've got the reference there for you. And it's done by Bosch and Lohm, but it's very helpful. You can click, when you're done, you click on this. I felt it was non-biased. And a lot of pictures will come up, pictures of different lenses. And I chose these 3, and then I clicked the button, Open Comparison Table. And this is what came up. And I circled 3 things that I thought were interesting. It gives you the model number, and you see on the Alcon, there are a lot of different model numbers for a lot of these things. And so I can keep them straight this way. And also down at the bottom, it tells you what the power options for sphere, what the range is. And I find that helpful because sometimes I go, does this lens come in a 33 diopter or not? So here's a question I have for the audience. How do you measure axial length in your practice? Optical biometer, applanation ultrasound, or immersion ultrasound? 75% use an optical biometer. Oh, that's wonderful. Applanation is not as accurate as an immersion. And if you're going to use, by accurate, it's not as accurate, nor is it as precise as immersion. If you're going to use an ultrasound on a toric IOL, you really want to get the sphere correct. So you probably should use immersion. So what's the ideal toric patient? There's some obvious things and some not so obvious. The obvious thing is they have to have money to pay for the lens and they have to have astigmatism. Not so obvious, they need trust. And maybe less obvious, the surgeon needs trust. Nothing builds success like success. So I'm hoping to help guide you to get your best options so that when you start, you can start trusting it and have confidence, and then that'll help you and your patients. Let's imagine you have a patient in front of you. You need to define what success looks like for that patient. Is it I want a big improvement? If so, you might give them a high power. You go for high power on those people, like a T6 to a T9. Or you have the other person who says, I want it perfect. I want to have excellent vision at nighttime and never use my glasses for driving. Okay, and that kind of person, you want the lower toric, the lowest astigmatism, T3 to a T5. Now, I did not start with a T3. I mean with a T2, which is the lowest for many of you, because a T2 is not available in the United States. I assume that's an FDA thing. I'm not sure. But I'm going to extrapolate from some data that I put together for this talk to try to give you some advice. So again, we're looking at those. The concept is you want either a big improvement or you want a perfect. And don't offer your patients both for your sake. So this, again, it's an unpublished study. And this is from a Veracity data set that's owned by Zeiss. And Zeiss was, I'm grateful that they let me use this for this talk. They collect their data through an electronic medical records application that doctors all across the US use, many doctors. And when they do, they use, this is real world data. So it's not for a study and it's not with perfect conditions. And it's only FDA approved lenses because these are it's only available in the United States. But it's a very large data set. And in this study, I used 30,000 toric lenses. I used 136 IOL models, and all these, the below, each of these are 4 examples of models that were used in the T3 portion for this study. I lumped them together, and I should say first, I excluded all eyes with vision worse than 6.6 or 20/20. There were 16,000 I excluded, And then I also excluded the lenses that use the first version J&J Toric lenses. There were only 300 of those eyes, and I excluded those because those IOLs were known to rotate. So these are all the current IOLs by these manufacturers. And again, there are 30,000 in this study, and you can see how many eyes were in each in this data set. Not so many in the T9, the highest powers. And what I studied was residual astigmatism after everything was done compared to the toric IOL power. So here's the graph. Now I define success here for this graph as the final astigmatism was less than 0.5 diopters. Perfect success would be 0 astigmatism, no magnitude at all. But nothing's ever perfect. And so this is, how do these people do? Well, you see in a T9, success was only about 45%. And each of these lines represents one of these platforms. So all the T9s were lumped together from, let's see, the blue would be Technis. Those were lumped, and the average was put down here. By average, I mean, there were 40, it was not really an average. There were 40% of them hit the success target. So the reason if somebody wants perfect, you don't want to use these higher power lenses because they're on, they're somewhere around 50, 60% of the time they're perfect. But on the low ends, look, you get some really high values. So I extrapolated, well, let me show you the 0.25%. You'll see, I'm going to go back and forth. The curve between these, really the slope is almost identical, which I find interesting. But the T9 on these is only accurate within a quarter diopter for 25% of the patients. However, T3 is up at 60% range. It's interesting how all of them follow the same curve next to each other. That says to me that these lenses don't rotate any differently than each other. If one of them rotated a lot, they'd have a very low number at low percent here. But you see they hug each other, and then the 50% is even closer, 0.5 diopter is even closer. They hug each other very tightly. And so it was easy to develop a regression formula to see, well, how would a T2 do? And that's what I have here. T2 is in success 89% of the time. So if you want your patient to be perfect, that patient wants perfect, you want a low power. But are they going to get a big improvement? Unlikely, because it's only a T2 only has 1 diopter power in it. And so it's likely if they're looking for a big improvement, it's going to be on the sphere part, not on the sill part for these patients. On the other hand, a T9, 46% ended up perfect, which is my definition of that is half diopter. So about half of them ended up perfect, and it's unclear about the improvement. So I studied that a little further with 86 of these eyes, these T9 eyes. And again, remember, they have post-op, all these have post-op refraction of 20/20. So I trust the post-op refraction. And all of them had 20/40 vision or better initially. So I trust their pre-op refraction. Why does that matter? Because I looked at those people who had an axis that was greater than 25 degrees off of where they started. Those are the ones that might give you trouble, at least if they have more than 1 diopter magnitude. And I've done a lot of patients with toric lenses. I have a lot of them who have a different axis than where they started. It's off by a lot. If the astigmatism is a diopter or less, they really don't complain about it. When it first came out, I was nervous. Can I overcorrect this thing overshoot it by 0.2 diopters? You've got a lot of leeway. If they're improved in their total sill and the total sill is less than 1 diopter, they're going to be happy. But this group, there were 13% that had an axis greater than 25 degrees and a cylinder greater than 1 diopter. So some of these you're going to have to take out or they're going to be unhappy. So what would I tell my son? If he came to me and he was an ophthalmologist and he said, Dad, what should I start with? I'd say start with a T2 to a T4. Avoid perfectionists. Nothing breeds success like success. So make sure your initial cases are highly likely to succeed. You need to choose wisely if you want to have success. So at the end of the talk, that'll be coming soon, I'm going to show you about Barrett integrated Ks. I'll mention those, but don't worry about it. That'll be coming. And I'll also show you how you can test your own system, your own topographer, your own keratometer, your marking system. You can test all of that low stress without ever using a toric IOL. And I'll show you how to do that at the end. So you can increase your likelihood of success. This part right here is talking about the Ks, the keratometry. Ks should be fairly symmetric. If you look at your topographer, you'll see if the right eye has astigmatism, steep axis that points in this direction, steep meridian, your left one's going to point in this direction. Or they're straight up, but they almost always are symmetrical around the vertical axis. Why does that matter? Because if you have one eye that's pointing at 90 and the other is at 45, yikes, that's a way you can tell there's a problem just from your keratometry. Also, beware if K1 or K2 is greater than 50 diopters, because those people are much more likely to have keratoconus. Use the Barrett integrated Ks, especially when you're starting. And for those of you with topography, a bow tie pattern is good, but use the Ks from your optical biometer, not the Ks from your topographer. They look pretty, but they don't work as well. And of course, beware of irregular corneal surface. So this is an example of somebody that does not have a great bow tie. Is steep on one side and not on the other. My topographer is an Atlas 9000, and it tells me it's a 37% likely keratoconus. I doubt keratoconus in this eye, but I don't see a strong bow tie. I see a little bit, and the part that matters is just this section right here. That central part is where you're going to look for the bow tie. So I'd be a little cautious about doing a toric on that one. This is a different patient, and you see here they do have a pretty good bow tie. And here it's a wonderful bow tie. So I would be very interested in using a toric on these. So this one, I'll look at the symmetry here, by the way. You see this one points over about 30 degrees, which is about 60 degrees off of 90. And this one points at about 150, which is about 30 degrees off of 90 in the other direction. And this one is also symmetric, but it's pretty close to 90 degrees for both. But it's common, like this one is maybe at 92 degrees, and the other one's at maybe 84 degrees. So just look for that in your Ks to help you. But on this one, they've got a steep bulge maybe down here at the bottom. So it makes you nervous about keratoconus. So we're going to talk about how do we adjust things for astigmatism in such a patient. On this patient, I would in a heartbeat do toric IOL on this patient. But if I knew what the posterior curve looked like, we have an anterion. These are patients I love that anterion for because I can see the posterior curve. Same thing could be done with a Pentacam. I don't have a Pentacam. So if you can see the posterior corneal curve and you see it's a normal, there's no bulge, no bright spot, hot spot, well, then just treat it like a normal cornea. There's not any keratoconus there that's going to matter anything. So, but to help us with keratoconus, this is a publication, it's not published. This is also from the Veracity data set. And I looked at 700 keratoconic eyes, and I presented this at AAO, American Academy of Ophthalmology, last week or real recently. These are eyes, all of them had keratoconus, and the Ks were under 50 diopters. Now, not all of them were under 50. I had two groups. All of them were under 60. And it turned out the best formula for these under 50 was a non-keratoconic formula. It was the RBF 3.0. So if you have a patient like that last one where there's a bulge and you don't have access to the posterior cornea and you're not sure if it's keratoconus or not, you don't need a keratoconus formula. Just use your standard formula and then it'll cover it for either way. That's if the Ks are under 50. Again, if you have a posterior access to a posterior cornea, it's amazing. So keratoconus with Ks over 50 diopter, the best one was actually the SRKT. Right next to it was the Barrett keratoconus formula predicted. Now, if you have the posterior cornea and you can use the Barrett keratoconus measured, meaning you have posterior Ks, that group does the best. So on LensStar, this is a LensStar on this particular patient. And it turns out it was a very short eye, and short eyes are commonly, they have high Ks, and the Ks were not greater than 50. So this patient doesn't bother me about keratoconus, even without knowing the posterior cornea. Keratoconus in general, you overpower the IOL sphere and you underpower the IOL cylinder, but I wasn't happy with that. I needed more information. So I studied it. And for sphere, you don't have to change anything. Just use those formulas I mentioned. Then you don't have to change your power over or under. And for cylinder, you underpower it by 2 clicks, but only if it's an oblique astigmatism, at least in that group. And there were a lot of Ks in there. So what that means is if the astigmatism is oblique and it calls for a T9, go down 2 and use a T7. If it's with the rule and it calls for a T9, use a T9. So with the rule is defined as the steep anterior corneal meridian between 60 and 120 degrees. So it points up. Against the rule, it points sideways. It's between 0 and 30 and 150 to 180. For oblique, it's everything else. So here are some eyes with maybe some keratoconus, but I would operate on these because you've got a bow tie in the middle. Maybe not a perfect one, but enough. This one for sure, I would, in a heartbeat, I would do that. And they've got a lot of astigmatism. We did another study, and it showed, this was on our lens star, if the standard deviation of the axis was less than 3.5, it was highly likely to do well. I have I would not choose an RK patient. I have one I'll show you in a minute, I hope. I had 20 incisions. Currently, he's 2.5 diopters, hyperopic. So on that one, I did use a toric, but from his perspective, the toric didn't work because the sphere was off. So be careful on the patient you choose. I have a question for you. If you have access, if you have access to an optical biometer, which one is it? And for this, you have to, the biometer has to use an axial length. IOL Master 500, IOL Master 700. Okay, now not all of those have posterior cornea, but the 700, half of you have that. If you can get posterior cornea, oh man, we've got some, it'd have to be a different talk, but there's some great ways to use the TK values and the PK values on that. So I'm happy about that. That's excellent. But that's for another day. So for astigmatism, I talked about the standard deviation on the lens star, and otherwise the IOL Master was actually better. So Pentacam Ks, we just recently published this, does not do as well as the IOL Master Ks. So if you have, some people ask questions, they had both. They had a topographer and an IOL Master. Which one should they use? Use your optical biometer Ks. Be cautious with Ks that are developed solely on OCT or placido disc. Reflective keratometry is better. For bare integrated Ks, look at that website. Now, you can test your accuracy. We'll come to that in a minute. But basically, you use the Barrett toric calculator, but don't use a toric IOL, and see how you do. You can increase your likelihood of success if you use good lens constants. So these are IOL constants if you don't have your own. And if you have ultrasound, you can substitute, at least immersion ultrasound, you can use it for the same as optical, only up to 25 millimeters. At that point, the ultrasound axial length becomes shorter than the optical axial length, and you're going to start throwing off your sphere. So if you have an ultrasound, immersion ultrasound, and you have a value greater than 25, you can adjust it with this formula. You can recalibrate it. You take your immersion ultrasound axial length right here, you multiply it by 1.02, and you subtract 0.46. And that's going to give you a value that's really close to your optical biometer. Again, you only need it for eyes longer than 25 millimeters. Review. Determine your toric goals on a patient. Set expectations according to what's likely. Look at those graphs I gave you. Avoid perfectionists. Avoid problem eyes like refractive surgery, axes that aren't symmetrical. Test your keratometry results before you use any torics. Adjust your immersion ultrasound. Question. I or my surgeon uses phaco or use phacoemulsification at least 70% of the time, less than 10%, or somewhere in between. Oh, wonderful. At least 70% of the time in 70% of the people. So that's very helpful. Then this talk, I got the right crowd here. I'm going to have to go faster because I'm taking too long. I'm sorry. How to repair a refractive surprise after implanting an IOL. Steps to repair a toric IOL surprise. Carefully refract the patient. Identify the axis of the current toric IOL. Those two things matter. Then you're going to enter your data into a toric recalculator. I call it a recalculator, like astigmatism fix calculator. And then you're going to surgically replace it. The most important step is refract your patient who has a toric IOL and it didn't turn out right. That refraction drives everything. You don't need another biometer. You don't need Ks. You won't use them. It's the refraction that drives it. Find the axis of the current toric IOL, and you can do it like this. You got a red reflex in your keratometer, and you got pictures of it, the toric marks here, and you can rotate the head. But what if your slit lamp has a head like this, like some of ours, and you want numbers like this? Well, there was an article that came out, tells you how to fix that. And I have a little video here of Tom in our office putting one on. And he lines up the 90-degree mark with the notch. The slit lamp is at the 90 degrees, and then puts it on. And you can see as he puts it on, it's just straightforward from that point. And then there's a little light that's at 60 degrees, and you can test with a protractor how your accuracy is. Now you're going to enter your data into a toric recalculator. Current refraction and the IOL details. There are options for these. There are 4 options that we looked at in this study. This one is the one that matters, the Barrett one. I'm hoping that my son and I will have this, ours up on the Cooke formula. I said that was going to be really soon, 3 months ago. It's my fault. I'm hoping I get it to him, but hopefully in another couple months, hopefully at least, it'll be on that website. So these 4 toric recalculators were evaluated on 34 patients. Those 4 items there on the left, those inputs are needed for every formula. For Cooke Light, we called it, it only uses those. For all these other formulas, they use a lot more questions, a lot more items, like all the preoperative biometry. Well, what if you don't have that? Or some other questions that you may not know the answer to. So this is the Barrett RX Exchange. Here's how you use it. Up at the top is the name, and then there's some buttons over there that are active. So you start here, you see this patient data. That when you're on that screen, right there, you want to use this formula, but you can't do anything. Oh, there you have to, those are active. You pluck positive cylinder or negative cylinder, and always click the ELP unless it tells you to use the other one, and it'll tell you to use IOL. So under patient data, you have to enter the patient data before you can do anything. Now, even though you've got it entered, you still can't click that formula. You have to click calculate first. And this right here gives you instructions what to do next. So you enter data and calculate. When it says view formula, now you can go up and click that. And when you do, then you get your outcome. It has to be in that order or you get stuck. And this tells you what to get. Astigmatism fix tells you what to fix. The problem is it asks for some things that are difficult, like what's the cylinder power at the corneal plane for your IOL? Well, we don't know that for some IOLs. What was the originally calculated axis? It gives you nice recommendations, however. The main problem with the Bird-All calculator is it only tells you what your results are with rotating. And in our office, I had to take the lens out 34 times and only rotated it once. Cooke Light and Cooke K6, they're not on the web, hopefully soon. So we're going to show you how to replace an IOL here. This is an IOL where I know where it is, so I put my ring down at the known mark, and then I want to. This one basically was a sphere problem, So I keep the mark almost the same. But you don't have to mark these patients externally before surgery because you already know where it is. You've measured it to the slit lamp. So you put your ring down. If it's at 133, you put your ring right at 133. Then every number on your ring should be accurate. And I've marked the axis there. I use a scleral tunnel. Most people probably don't. So I wanted to just show you how to do this. It's helpful in some cases. It's low astigmatism. Theoretically, maybe less infection. So I don't use cautery very often, and you'll see I get blood in my cases, but I can keep things pretty clean by just wiping the vessels. They spasm. I make a vertical cut through the sclera, about 50% depth. And then I'll come in with a diamond-shaped blade, and I'll go parallel to the sclera. And as I push it forward, I try not to push forward. I try to primarily cut from the sides. Why? Because I've 3 times had to go and slip. And one time I went right up into the corneal apex, and forever she was blurred. It was an older lady who didn't want a corneal transplant. It wasn't that bad, but it probably took a line or 2 away from her vision. So now I've dimpled down. I've gone into the anterior chamber. And as I put in the viscoelastic, there's a lens and an implant in there. As I put in the viscoelastic, I want to underfill the anterior chamber. I don't show it here, but I underfill it for 2 reasons. Well, I'm going to skip that. I've got a sharp Sinski here. It's important that tip is sharp. I go under and I pull up the anterior capsule. And now this is a patient. Okay, I pull it up. And I'm going to put viscoelastic underneath there. And this, I use Viscoat, but you want one of those viscodispersive so that it can blow open the posterior capsule. You have to get that capsule back open to its original size. I've done this on patients who've had lenses in a long time. My longest was 19 years, and still the capsule opened nicely, and the anterior capsule did not stick to the lens. Now, you need a pawing motion, like a pawing of a dog, to pull that haptic towards you. But if you pull it towards you, you'll rip the zonules and pull those towards you. So at the same time you're pawing towards you, you're blowing the sulcus or the equator of the lens bag away from you. So you blow it away and you paw it towards you. You don't tug it with an instrument or you're going to rip something. I think I said I've done 200 of these and I've not yet had the capsule stick to the lens. Now here, I'm grabbing it with forceps, and now I'm going to cut it in half, and then I pull the pieces through. See, I pull them through here. I'm going to skip. Now, this is a different one. This is a light-adjusted lens that I removed. A toric was being reinserted, but the capsule, the light-adjusted lens has Prolene haptics, and so they're very skinny, and I just rotated them out. I couldn't get this new lens to fit. It needed to go where that was. It was stuck. I had tried rotating it. I had tried putting in viscoelastic. I had already tried to visco dissect it, rotated it. It didn't help. So I'm going to show you. I just slow, keep your blood pressure down. Don't move fast. Lots of viscoelastic. I came from the other side. A high magnification. You'll see I release a band I can't even see. It's coming up. It's coming soon. It's about to release right here. Boink. And now it goes down into the back. These are the instruments. I don't get anything from them. These are in case those are the ones I use. Key points: go slowly. Initially underfill the anterior chamber with viscoelastic. Otherwise, use a lot of viscoelastic. It's your friend. Viscoelastic and time. My pre-op comment to every patient is, I might get in there and see I broke something and feel it's unsafe for me to proceed, but if I keep things where they are, it'll be safe. I tell you that, the patient, to keep my blood pressure down while I'm operating and to keep me from doing something stupid. I don't want to push too hard. I tell every patient that. I haven't had to use it yet. And you can amputate the haptic and leave it there. The 2 most important steps are lifting that capsule flap off of the anterior IOL with a pointed instrument. You can use a 30 gauge needle if you have to. Again, 200 times I've gotten it. And paw the haptic while blowing the capsule posteriorly. it saves your zonules while you tug those things toward the center. So who was this surgeon? This is a patient with 5.5 diopters of corneal astigmatism, less than that in her glasses. She had monovision. The left eye was for reading. The surgeon, did her left eye, and she was doing amazingly well. She's ready for her right eye. And when I did the right eye, she came in and said, my right eye sucks. Well, I had put the implant at 170 degrees instead of 80. So she started with like 4 diopters, 4.5. Now she has 9 diopters of astigmatism because I used a T9. I told her we're going to wait 3 weeks. Sorry, wait 3 weeks. Why? I want the bag to pull in. Maybe it rotated. When it's off that far, I think it was a surgeon problem, but maybe it rotated. I want the bag to track some so that the next time when I stick it in, it's not going to rotate. So I tell them all, if I have to do it, it's 3 weeks. There's no need to mark the eye. I know it's at 170 degrees. I put viscoat under the capsule and the IOL easily comes free. So you're going to see it. You can see a little bit of the mark right there. This is at 170 degrees, and you'll see the haptic, a little bit of the haptic there. These marks are always in the middle of the haptic, the base of the haptic. So there's the mark. So I want to put it up here at 80 degrees. So you'll see it's 90 degrees away from where it was. These Toric calculators are amazing. She ended up after this 1 week, she's 20/20 in that eye without correction. I actually do better if I have to reoperate. I get better results than my normal on the first time because I know exactly where that axis is, I suppose. I'm not sure. But anyway, I've marked them now, and I'm going to go in, and I'm going to, this is only 3 weeks out. I'm going to pull up this capsule, but it makes me nervous. You'll see the lens. I start pointing the capsule down here in a minute with my sharp instrument down, and the lens moves enough. So I start getting close to the posterior capsule, right there. Oh, that lens is moving on me. I don't feel I can comfortably get under there and elevate the capsule. So I go to a different spot. And the reason it's like that, normally that doesn't move like that, but this is a fresh lens. It makes it, the lens moves around a lot more. It's not solid in there. So 3 weeks is a great time to take one out, if you're going to take one out. So at this one, I lifted it up, and there's enough viscoelastic and all in the eye. I could get underneath it with my iris sweep. And now I go in with my viscoat cannula, go underneath there, and I just blast away and watch. The haptic is going to come toward me by itself. Just by blowing it forward, boop, it comes forward. It's very easy to get these out at 3 weeks. And then I come from the other side. I do the same thing. And I always, as I blow, I try to do a gentle pawing motion, maybe on the optic, maybe on the haptic. But here you'll see I'm pawing that lens toward me. I'm not tugging it, and I'm blowing the equator away from me while I do that. And now I'm going to show you how I rotate it. Several of you asked about that. It's just simple nudging it. Nothing fast, slow. And I'm going to get it till it lines up with that axis. So these are the results of 34 diopter toric IOLs, 34 toric IOLs that I exchanged. This is with Cooke light, and you want these, I'm not going to explain them, it's a double angle plot. You want these circles as small as possible. That shows that you did well. You want the centroid, that black part, in the middle, and it is. So it did well on these 34 eyes. So here's Cooke light, here's the K6, it's slightly better, slightly smaller. Here's the Barrett, slightly worse than the K6, but they're all really very close. And you can see here there were 34 eyes. I ranked these by the ellipse area, which is like the standard deviation. The K6 was slightly better than the Barrett, slightly better than the Cooke light, but all of them are really identical, which means all you really need is your refraction and where the IOL is. We only had one eye that we rotated, so we could use the Berdahl calculator. And you see, again, they're all the same. These I ranked by cylinder magnitude. So they're all the same amount, but that was an N of 1. So now the board, you're ready for the Toric calculator. You're ready to actually do a case. So you put in patient data, enter the doctor's name, you push calculate. You can now enter measured or predicted. And when you do, something happens. When you push calculate, now here's before you push calculate. Now when you push calculate, it tells you what the astigmatism should be with no toric IOL. You're going to use this, that level I'm pointing at right there. You're going to use that to your advantage. You're going to test yourself with this. You put in a sphere IOL, you use the Barrick, and it's going to tell you what prediction you should have for astigmatism, you're going to see how well you do. If you're spot on, then the Barrett calculator worked, and so did your Ks. So you can test your Ks. So in this example, you should have 1.5 diopters of astigmatism, and your K should be pointing at 119 degrees. This is what I'm really worried about. I want to point out here because this is all about astigmatism. Well, both those are. And so you're going to test yourself and see. The other thing you should do is when you're in the OR, mark the patient, just like you're going to do, mark them in the pre-op area, and then use your toric marker and, identify where 119 degrees is, and then make a little nick in the conjunctiva right there at the limbus. So that's your axis you were going to use. So record your axis at day 1, see what you really were at, and then record your astigmatism, make a list of 20 of them, send them in. If we can get Andy to make this work at cyber site. But once we've got 20 docs who have given a list of 20 each, then I'll try to see if we can get some basic analysis. You're going to need these things: K1, K2, axis for K2, final refraction, and vision type. I need to know the biometer type and what the just biometer type, and whether your vision is decimal or what type it is. Test your accuracy before you start. Your axis should be ideally at 5 degrees, but 10 degrees is acceptable. Your astigmatism should probably be within 0.75. Why not 100? Why not exactly? Because the Barrett calculator is not perfect. See what your axis is most accurate and then use that. Typically, the axis is most accurate with the rule. So pick with the rule patients for your first ones. But you're going to test yourself and you're going to see. Now you click Toric. Before you just done the calculate, and this is going to tell you what lens you're going to use. And here's your Barrett integrated case. You click on that spot right there, and then it gives you 3 options here where you can enter case from all 3 of your calculators. For the actual operation, I didn't spend much time on this. It's similar to your standard surgery, except the marking part, which you're going to figure out. You'll use your iPhone. Be careful not to put the IOL. Sometimes you'll put an IOL in the bag, even if the bag has a little rupture. I would not do that with toric because you can't adjust it. Align the toric lens. Remove the viscoelastic under the lens. Leave the eye soft so that lens is more likely to stay in position. And make sure the patient is numb when you mark them so you don't get a Bell's phenomenon. You have to mark them sitting up because some eyes will rotate when they lie down. Use your best incision, not just the one I just showed you. You don't want a new incision on an important case. Remove the viscoelastic, leave it soft. Oh, some evidence that you should have the patients lie still for an hour afterward. Don't be afraid to remove or rotate it, but only do that if you know the bag and the zonules are intact. Wait 3 weeks for it to tighten some. Remove Technis IOLs as soon as you can. The bag scars to the IOL haptic junction, the optic haptic junction. Question, choose one. I'm planning to test my system without actually using a toric IOL, or I'm beyond that step. Oh, wonderful. 2/3 are planning to use it. Next clip, this is an eye, we had a 20 incision RK. There was no room for an incision. It turned out to be really helpful to do the posterior corneal, the limbal scleral tunnel incision. And on this one, marking the eye here. I'm going to skip ahead a little. Question, my toric fears are the same as they were, worse than they were, a little less than they were, a lot less than they were. I have no fear of anything. A little less. We made some progress. A lot less in some. Oh, wonderful. Worse than they were in 16. Sorry, guys. And about the same as they were. Okay. And not some have no fear of anything. Oh, good for them. May I not be that doctor's patient. I want my doctor to be a little afraid of something. So next clip we'll skip. It was about how if you can't see the capsule. I I do want to show you irrigating under the capsule and how to be certain the IOL is in the bag. So I'm inserting the IOL here. The capsule bag is full of viscoelastic. I can see my inferior haptic. I can see where it went under the capsule there. You can't see it very well in this video, but I know the bag is right there. I know that haptic is in the bag. I always rotate these things until I know this one's also in the bag right here. Even if it's a small pupil and I can only see in that little area, I move the lens to that little area twice so I can see. And you notice that as I'm moving, I'm just lifting up the IOL so I can irrigate underneath it. And I'm going to show you, this is one more. This is a small pupil, and how do I get under the lens here to irrigate underneath it? So again, I know I was able to see the capsule edge right there. I put that edge underneath it. Now I'm going to rotate it, so I put the other haptic underneath it. Now look, I pick up the lens with my viscoat and I put it underneath, so I hold that lens up. Now I put in viscoelastic so I can take out the viscoelastic. And I'm not very aggressive in underneath. I've got my irrigation port pointing down, so I blow down BSS while I'm aspirating beside the lens. And that's it. Let me go to questions. How do I determine the most accurate corneal astigmatism measurement before choosing the toric lens power? So we actually have a program that my son wrote where it takes automatically the 3 different machines measurements. And if the sphere and the toric were really close to each other on all of them, it highlights the box green. And I don't remember exactly what we chose, but probably the degrees had to be within 5 or 10 degrees of each other. And the power, the toric, the total magnitude of astigmatism had to be probably within 0.6 diopters. And then it'll put a green box. If it's a little higher, it puts a yellow box. And if it's more than that, I don't trust the astigmatism. That's rare that I would do it. Which biometry technologies or formulas do you rely on the most? I think I said that. It would be the IOL Master, the reflective keratometry. So it'd be IOL Master 700 or the Lens Star if it has a standard deviation of less than 3.5 degrees. And those are the 2 I have access to. But I would probably even use an IOL Master 500. In fact, if you guys can test it, test your 500 and see if it's good enough. How do you manage discrepancies between topography and tomography and keratometry? I go as reflective keratometry. I don't trust the other 2. I trust the pictures, but not the sim case. Do you use intraoperative aberrometry? No, I don't trust it. Minimize rotational instability. Leave the eye a little soft. Have the patient lie still. I do not use a digital system for alignment. With irregular astigmatism, it depends how kooky it is. The one thing in my favor is with irregular astigmatism, the toric lens does not add extra aberrancy into the system, whereas a multifocal toric does. So if it's an irregular astigmatism, I would not add the multifocality or an extended depth of focus. I would just use a pure toric on irregular astigmatism. They asked about the toric. Can you use toric with an extra cap? In other words, you don't have phaco? And the answer is yes, but you need to know how much your incision affects the astigmatism. My encouragement would be to start with, well, it depends on whether you do superior or temporal incision. But if you're superior incision, the best thing to do is to just divide your cases into with the rule and against the rule cases and do 20 of each and compare what does that Barrett calculator give for astigmatism compared to what you get. And if you're always getting less astigmatism on your with the rule cases, then go down on your toric cases. Yeah, toric calculators are different. They ask why. I don't know why. I'm in the middle of working really hard to get our own. I tell you the ones I trust: Evo, Barrett, and Pearl DGS. Those do quite well. Evo seemed, if I had to pick one right now, I'd pick the Evo one. I don't have the websites for those, sorry. So with the IOLmaster 700, Seth Pantinelli did a study on astigmatism. It's not exhaustive, and it was with using only preoperative values. It was using preoperative values and comparing how consistent they were. And he found that TK1 and TK2 were more consistent than K1 and K2, but I'm not sure about using them in a Toric calculator. His recommendation is to use those in a Toric calculator instead of the Ks, because he said the results are about the same and your consistency is better. I use Ks in my Toric calculations. Do I use phaco in keratoconus? Yeah, but if they have a real thin cornea, I try to avoid the thin spot. Like if they have pellucid corneal, pellucid degeneration, then I would try. And I just did one of those. I would use a Toric. One of the issues with Toric is if you think they're going to have a full thickness corneal transplant, I would not use a high Toric if there's a pretty good chance for a corneal transplant, because now you're going to put a new Toric in. You might double the astigmatism like I did when I had my lens at the wrong axis. Yeah, the Alcon Panoptics and the Clarion Panoptics does not come higher than a T5, I think. Yeah, so somebody says the IOL's in the right spot, just like you predicted, but there's still a lot of astigmatism after surgery. And so the question is, why? What do you do? Why was it like that? Well, either your Ks were wrong or this patient has hidden astigmatism. And 15% of patients have posterior corneal astigmatism or astigmatism coming from somewhere that you can't measure preoperatively. So that's part of why I feel you need to be able to take lenses out and calculate. Okay, I got a surprise. Now that you know the surprise, now you know the right answer. There is no longer any hidden astigmatism. It's in the refraction. And so you can fix it. But you're going to get it. It's either that there's hidden posterior corneal astigmatism, or you're not getting good keratometry, or maybe they had really dry eye on the day you tested them, and maybe your initial Ks were wrong. So what I do on a patient like that is I'll usually just make sure that I haven't used a lot of artificial tears and recheck the Ks. That's the simplest. Yeah, I think definitely you can use Toric IOLs with extra cap incisions, but I would probably only do T4, 5, and above. I probably wouldn't do a 1 or 2. I mean a 2 or a 3. On what do I determine the astigmatism? On my Ks of the topographer, on my Ks of the biometer, not of the Ks of the topographer. I do make a different incision based on the axis of the astigmatism. So that's all part of my calculator. But I've looked at it. When the incision is back as far as mine is, it doesn't add much at all, about 0.1 diopters. What SIA do I recommend putting in if temporal incision near the limbus in a 3 corneal incision? Thank you very much.